Now we're going to move from surgical options to non-surgical treatment options, and this will be presented by Dr. David Ilson from Memorial Sloan Kettering Cancer Chair. He's also the chair of our Medical Advisory Board, as you heard already. And I just also want to mention that he's been selected to receive the Medical Tree of Life Award for his contributions to the field and role of the downstream Foundation. Thank you so much for that. Let's give him applause. Thank you.
Okay, well, obviously, thanks very much for the invitation to speak, and I just want to echo the comments from Manish and Dan about how much a privilege it is to care for patients with gastric cancer and other cancers. I mean, we want to empower you, but you also empower us to try and move the mission forward. And I just want to thank all of you here today very much. I'm going to focus now on non-surgical treatment of gastric cancer. And I kind of look at this lecture as sort of a roadmap. You know, what have we learned from studies that look at different chemotherapies, that look at application of different therapies? And the other thing is a caveat. You know, oftentimes we look at statistics, and I think some of our panelists earlier today show that everybody writes their own book with a diagnosis of stomach cancer, but that a lot of statistics are averages, which means that half of the patients don't do that well, but half of the patients are above the average. So, and always we have to assume that every patient is going to do better than the average. I just want to couch some of the information that I present that these are averages and from controlled studies, but help us guide our thinking and how best to design treatments that are best for each individual patient. These are disclosures. So, as we've seen and talked about earlier, gastric cancer is a disease that varies really tremendously around the world. In fact, in East Asia and Japan and China, you can see on the left, this is a very common cause of cancer. There's a more intermediate incidence in places like Eastern Europe and tropical South America. But then if you look towards the right-hand side of the curve, in Western Europe and North America, this is a relatively uncommon disease. And in places in the world where this is very common, there are active screening programs. Where this disease is less common, it's more difficult for screening and early detection. And that being said, I think there are studies ongoing to try and address higher risk groups of individuals that might benefit from screening and early intervention. And this is a leading cause of cancer-related mortality worldwide. It's the third leading cause of cancer-related death globally. So Manish discussed these statistics earlier. If we look specifically at gastric cancer, it's not uncommon. Over 25,000 cases a year. We are seeing a shift in the epidemiology of gastric cancer, and I think a lot of that has to do because this Helicobacter pylori infection we're really kind of eliminating from Western populations because, we have better food preservation now. This is actually a risk factor that's decreasing in the West. But then a shift in the epidemiology to more tumors of the proximal stomach, the esophagus, and the GE junction. And survival improvements have clearly been incremental over the last 3 decades. Still, there's a huge room for improvement. And I think that the improvements in survival, as I think Dan discussed, we have better surgical selection of patients, we do better surgery, we take care of patients better after surgery, and there has been incremental improvement in preventive strategies after surgery, such as adjuvant treatment using chemotherapy and, to a lesser extent, radiation therapy. So when patients present with gastric cancer, again in the West, unfortunately there just is not an effective screening for this disease because gastric cancer only occurs at an incidence of 10 to 20% of screened cancers, and it's just very hard to justify screening for a rare cancer when 99.9, most of the time when you do these screening interventions, you're not going to find anything. And familial gastric cancer, which we talked about earlier, it's rare. Once we identify families that are high risk, we can do genetic counseling and testing. We can integrate screening or even preventive surgeries. But familial gastric cancer is rare. It's a small percentage of this disease. And as a consequence of this, and as we heard from our panelists also, patients present with symptoms. They're symptomatic. And because of this, 30 to 40% of patients have metastatic disease, have stage 4 disease at diagnosis. And then the other sort of problem is that even that patients that have localized disease, again, because of the early spread, about 20 to 30% of patients that are potential surgical candidates have what we call peritoneal disease found. Dr. Coit mentioned laparoscopy. We want to take a look in the abdominal cavity before we commit a patient to surgery. And about 20 to 30% of patients that we look at have involvement of their cancer in the lining of the abdominal cavity, or when the surgeon washes the abdominal cavity, they find cancer cells. And that really, at least initially, those patients are not likely to benefit from surgery. And then the other problem is, again, even the patients that we operate on have, often very locally advanced cancers, so that the recurrence risk after surgery can even exceed 50%. So this is a daunting task for us, looking at patients that present with this disease. So, and I know, Dan, you commented on the benefit of adjuvant, post-surgery treatments. We have made some progress. I mean, clearly a lot of room for more research. But if we look at applying chemotherapy in combination with surgery for gastric cancer, we have made modest survival improvements. So it's now part of standard care to combine chemotherapy with surgery in patients with locally advanced disease. The initial U.S. approach was to give post-operative radiation and chemotherapy, and that translated into a modest improvement in survival at 5 years, about 10% more patients. But then it became increasingly evident that if you did better surgery, if you did better quality surgery, that probably chemotherapy alone combined with surgery gave a benefit. And the first positive results from this came from the United Kingdom, giving pre- and post-operative chemotherapy without radiation, and again, getting that kind of same survival benefit, about 13% with chemotherapy alone. And then even chemotherapy after surgery has come back as a treatment option, as long as you get good surgery. Huge studies from Korea and Japan treating thousands of patients indicate that chemotherapy for 6 months to a year, as long as you get good surgery, that there is some preventive benefit. But again, they're modest benefits. We're not hitting a home run. We're getting some survival improvements with chemotherapy, and we clearly need to identify more active treatments. We need to study the genomics of cancers, look for new targets. But we have made progress, and chemotherapy added to surgery does improve outcome. So what about patients that initially don't have operable disease, but it's still regional? And we'll talk about the role of surgery in patients that have metastasis in other organs, and that's really an individualized approach. But patients sometimes will have very extensive local disease. They'll have lots of lymph nodes regionally, primary tumor with lots of lymph nodes. And then our surgeons would say, well, if there's a response to treatment, we might revisit doing surgery. And indeed, in some of these patients, if we apply chemotherapy and sometimes combine chemotherapy and radiation, and there's a good response, we might reassess those patients to do surgery down the line. And actually, it's probably this subgroup of patients with regional disease that we would consider maybe a little more aggressive chemotherapy. Maybe it helps to not just give a standard platinum and 5-FU drug, but possibly add the third drug, the taxane. And that would be regimens like modified DCF or FLOT that we'll talk about. And then sometimes we really get lucky when we combine chemotherapy and radiation for these locally advanced tumors. And we know from historical literature about 10 to 20% of patients, there's no cancer found at surgery. So for patients with locally extensive disease, we probably would consider aggressive chemotherapy up front, maybe radiation therapy, and depending on how patients respond, consider for curative surgery. So then, why not just take everybody's stomach out when they're first diagnosed? And we always like to look at studies, and I think the Japanese, who obviously see a lot of gastric cancer, actually asked this question in a randomized trial, the Regatta trial. This was published earlier this year in the Lancet Oncology, and they took 175 patients with newly diagnosed stage 4 metastatic gastric cancer. And these were patients that had really kind of one site of disease. So they weren't patients that had tumor in many different places. And about 3/4 had this peritoneal involvement, so tumor in the lining of the abdomen, and about 15% had extensive lymph node disease in the abdomen. And they did a trial. They compared patients just getting chemotherapy, and chemotherapy is the standard treatment for stage 4 metastatic disease, or asking the question that every patient asks, why not just take my stomach out? So they actually did gastrectomy and then gave the patients chemotherapy. They wanted to see, is this the right thing to do in all patients that walk in the door? And they gave standard chemotherapy, 5-FU, an oral 5-FU plus a platinum agent. And it turns out that actually the patients that got upfront surgery did inferior. They did worse. They had inferior 2-year survival by about 7%. And they also had a lot more side effects from chemotherapy. So because they had their stomach out, a lot of 5-FU platinum chemotherapy causes a lot of GI side effects. And they actually didn't tolerate treatment as well. They had much, much higher rates of severe toxicities from treatment. So I think what this trial tells us, and it doesn't say that you shouldn't ever have surgery. It just says that every patient that walks in the door with metastatic gastric cancer probably should not get surgery up front. And I think that is an important teaching point. And if you look at the curves on the right, that looks at sort of progression-free overall survival, and actually the patients that got surgery did worse. Now, that's not to say that you should never have surgery if you have metastatic gastric cancer. It's just that when you walk in the door, it's probably not the right thing to do initially. And then any decision to do surgery down the line needs to be individualized for each patient. So what are the issues in trying to decide what's the best chemotherapy when patients present with stage 4 disease? Well, I mean, unfortunately, in many of these patients, curative surgery may not be feasible, just may not be possible. So the goal of chemotherapy is to control the disease, to keep it in check, to relieve symptoms, and to maintain the length and the quality of life for as long as possible. And again, everybody writes their own book. When we make a decision about what's the best chemotherapy to give patients, we have to look at the patient's age. Obviously, age is really, in the eye of the beholder. I mean, you've got, marathon runners that are 80, but an 80-year-old may not tolerate aggressive treatment as much as a 40-year-old. So age, also the functional status of the patient. Is the patient ambulatory? Are they active? Do they have a lot of medical issues? And certainly this is a disease of older patients in the United States. I think the average age of a gastric cancer patient in the United States is in their late 60s. So we have to look at their medical issues. Do they have diabetes? Do they have kidney disease? Do they have high blood pressure? Do they have heart disease? So even that being said, most patients with metastatic gastric cancer will likely benefit from combination chemotherapy, more than just one drug. So combination chemotherapy, usually with 2 drugs, is the preferred treatment over single chemotherapy drugs. And typically, we're going to recommend single chemotherapy drugs with drugs like 5-FU or oral 5-FU capecitabine or single-agent taxanes in really our older patients that just aren't well, that they just aren't strong enough to tolerate the rigors of combination chemotherapy. But then on the other extreme, we might think about more aggressive treatments for younger, more functional status, younger patients without medical problems, without comorbidities. And also, this is informed consent. I mean, if we're going to opt for a more toxic treatment, we have to discuss with patients that you have to be willing to tolerate more side effects, and we've got to see you frequently. But again, as we'll show from the data, probably most patients are in the middle somewhere. They probably should get 2 chemotherapy drugs, and we might reserve adding a 3rd drug like a taxane for younger patients, or for patients that, I told you about the locally advanced patients that we might think about surgery later, that we're willing to tolerate higher side effects in the short term if we're thinking of doing local therapies early on. So I've been in practice now for over 2 decades, and when I first started practicing, we had pretty toxic treatment. We were kind of married to giving 5-FU and cisplatin in probably the worst possible way we could do it. We gave 5-FU infusions over 4 or 5. We actually used to admit patients to the hospital for this. We would give patients 4 to 5 days of a 5-FU infusion and a very high dose of cisplatin on the first day, and they would have kidney problems, and we'd have to give them liters of fluid and nausea medications, and in the hospital for 4 or 5 days. And only about 20 or 30% of patients responded to this. And the survival, again, it's an average, so it was only about 8 or 9 months. And I remember when I was practicing, I just was appalled by this treatment. I said, we have to do better. There's got to be some way we can give these drugs that make it more tolerable, make it easier to give. And then over the ensuing decades, we did discover that we can use these drugs better, and also some newer alternatives that might have less toxicity. So recent studies, and we'll go over the results, that oral 5-FU, capecitabine, can replace the infusional 5-FU. Oxaliplatin is probably the preferred drug now over cisplatin. It's a lot better tolerated. And then the other thing we learned from our colon cancer colleagues is that if you schedule chemotherapy once every 2 weeks, you do a lot better. So colon cancer scheduling really revolutionized how we give these drugs, and we went from an inpatient, pretty toxic treatment to an outpatient treatment that could be maintaining the effectiveness and really optimize patients' quality of life and minimize treatment-related side effects. So I've included this slide, rather than going through all the studies of chemotherapy that have been done over the last 20 or 30 years. The way that we identify better treatments is we compare one chemotherapy versus another. So if we look at the right side of this graph, these are kind of the industry standards of chemotherapy. That S1 cisplatin, that's Japanese, that's oral 5-FU plus cisplatin. DCF, that's one of the 3 drug regimens that's fairly harsh. And then ECF, this is the British regimen giving epirubicin. And you can see, about 40–50% of patients respond from these treatments. But how long are they on the treatment? About 5 to 6 months. And again, an average survival time of a little bit less than a year. But then look at the middle of the chart. Those are the 2-drug chemotherapies. So XP is capecitabine cisplatin. Flow, that's a German version of 5-FU oxaliplatin. FOLFIRI. The remission rates are the same. Response rates are the same, about 40%. The time of patients on chemotherapy is about the same, 6 months. And the survival is not inferior for 2 drugs versus 3 drugs. And these are better tolerated regimens. 3-drug regimens, again, have a lot more side effects. So the Germans did a number of important randomized trials to help define this. And one of their early studies compared head-to-head oxaliplatin and cisplatin. And if you look, the flow is the oxaliplatin, the FLP is the cisplatin. And the time on treatment, patients actually had a little more time on treatment when they got oxaliplatin. It was better. And actually the response was a little higher, 34% compared to 27%. So substituting oxaliplatin for cisplatin certainly didn't compromise the effectiveness. And then they looked back, again, remember I told you, age is a consideration. You don't want to hurt people with more toxic treatment. So again, the upper panels show that, this is progression-free and overall survival, so you can see those curves overlap. So that means oxaliplatin behaved the same way as cisplatin. But then look at the bottom, and those are the patients treated on this study that were over the age of 65. And the blue graphs got oxaliplatin. So older patients actually did much better when they got a less toxic oxaliplatin compared to cisplatin. So this is one of the reasons that oxaliplatin has really replaced cisplatin in the treatment of this disease. And certainly in older patients, they did better when they got a less toxic alternative. Because many of my patients, I sometimes walk into the office and I say, I tolerated this treatment pretty well. Shouldn't I be sick? Does that mean it's not going to work? No, you don't have to be sick to benefit from chemotherapy treatments. So then the British did a number of studies comparing these drugs, and here you can see this is a survival with oxaliplatin versus cisplatin. There's no difference. Here's another one, infusional 5-FU versus oral 5-FU capecitabine, no difference. So these are equivalent treatments. I have to say, a caveat though, that the oral 5-FU I think has more side effects in terms, In the short term, maybe not, but the oral 5-FU causes what we call hand-foot syndrome, and I usually opt to give my patients the short 2-day infusional 5-FU rather than oral 5-FU, but certainly the oral 5-FU is acceptable and can be substituted. And here are studies from Asia. This is from Korea, looking at capecitabine also being equivalent to IV 5-FU. So we can use these potentially newer drugs, oxaliplatin, capecitabine, without compromising any effectiveness. So this is something I always fight with my British colleagues, because epirubicin, ECF, the British always include this drug with their chemotherapy, and they have never done a randomized trial to show that this drug really adds anything. I mean, and the problem is, when you get platinum 5-FU or 5-FU oxaliplatin, the side effects are manageable. Epirubicin, you lose your hair, you get mouth sores, you get nauseous, it could scar your heart. So I asked my British colleagues, do we really need this drug as part of treatment? So this was a study from France that actually didn't get a lot of play when it was published in the JCO, but they asked the question. They compared 3-drug ECX, so that's epirubicin, cisplatin, and oral 5-FU, to 2-drug FOLFIRI, 5-FU irinotecan. And if you look at that curve on the left, that's the time that patients were on treatment. So the blue curve means it's better, and actually the FOLFIRI, the 2-drug treatment, was better than the 3-drug British treatment because we had less side effects. And then if you look at the outcomes, the response rate was the same. So if you got FOLFIRI or you got 3-drug epirubicin, you had the same chance of responding to chemotherapy. You were on treatment about the same time, and survival was about the same. So this study provided early evidence, and there are other studies I could cite, that this drug epirubicin really should, probably in most patients, shouldn't be given. It just adds side effects. You don't want to give patients side effects if it doesn't help treat the cancer. So I think the most commonly used 3-drug chemotherapy regimen adds a taxane, Taxotere, to platinum 5-FU, and this was the a randomized trial. We compared 2 drugs versus 3 drugs. And this was a trial conducted in the US and mostly in Eastern Europe that compared CF, cisplatin 5-FU, with or without Taxotere. And you can see DCF is the 3 drugs. CF is the 2 drugs. Now, if you look, the average age of patients on this study was 55. So that's about 10 to 15 years younger than most of the patients that we see in the United States. And if you look at the response, okay, so the people that got 3 drugs did respond better. So there was a higher response, 37 versus 25%. Patients were on treatment longer, 6 months versus 4 months, and there was a trend, there was maybe slightly better survival with the 3-drug treatment. The problem is the side effects. So, and again, these are 55-year-olds, so imagine how a 70-year-old is going to behave with this. But, and these are really severe side effects that might lead to hospital stay or really symptomatic side effects. Mouth soreness in about 1 in 5 patients, severe diarrhea in 20% of patients, severe nausea and vomiting, neutropenia, so that's the lowering of the blood count to a life-threatening level occurred in about 80% of patients, and 30% had fever and low blood counts. And to me, one of the most telling statistics, if you look at patients that were taken off treatment for side effects or just said, I don't want this anymore, so that wasn't mean because it was not working anymore, it was just too harsh, or the patient said, I don't want this anymore, or the side effects were too great, it was 50%. So 50% of patients stopped treatment because of side effects. But it was better. I mean, it was slightly better. Anytime a curve is up, the upper level, there was some survival benefit for 3 drugs compared to 2 drugs. So Dr. Shah, I think, actually conducted a very important study where he tried to modulate the schedule of this treatment to lessen the side effects. So this is where modified DCF was looked at. This was a small randomized trial, but I think what Dr. Shah showed, that MDCF compared to the parent DCF, and if you look at the response, actually the modified DCF did a little better. Time on treatment was a little better, and survival certainly wasn't inferior. So I think this modified schedule of the 3 drugs is an option. But again, probably something we're still going to give to younger patients that don't have medical problems, that, that this still is, even though better tolerated, still not an easy treatment to tolerate. And then again, I want to quote the Germans again, because I think they did a number of studies to help us define not only what's the best treatment, but do treatments differ on patients' age. So this was a trial called FLOT 65, where they looked specifically at patients 65 or older in Germany. And they assigned them to get 2-drug chemotherapy with flow, which is 5-FU oxaliplatin, versus 5-FU oxaliplatin plus the DCF-like regimen. And this was 143 patients. The average age was 70. The response was higher. So people did respond a little better when they got the Taxotere, about 50 versus 28%. But other outcomes were not significantly better. There was no really significant difference in time on treatment, no clearly significant improvement in survival. But they also looked at quality of life. How did patients feel on this treatment? And it was much more toxic when they got the FLOT. And actually, they had much worse quality of life. So, okay, you got a little bit more response, you didn't feel better, and actually you felt worse. So remember that the name of the game, if we're not sure we're going to cure the cancer, we want to have patients on treatment that are going to get good responses, that they're going to be able to live their lives and not spend the time between treatments recovering from side effects. So over the age of 65, I would not give patients 3-drug chemotherapy. And here we just see it graphically. If we look at the time on treatment and survival, with or without Taxotere, there's no difference in those curves. The only thing I will comment on, however, in that lower left panel, remember I told you earlier that if you had a locally advanced cancer that maybe the surgeon's going to operate on, this did show that patients did better with locally advanced cancers. So if you have a cancer that you might get surgery or local therapies later, maybe we should err on the side of giving them more aggressive treatment. But in the upper panels, patients over the age of 65 with stage 4 disease, they do not benefit from more toxic treatment. So what do we do then after 5-FU and oxaliplatin? What's the next step? Well, these are studies that compared second-line chemotherapy with either Taxotere or irinotecan versus, and actually these studies, they did, the control arm was no further treatment. So did patients do any better if they got more chemotherapy with Taxotere or irinotecan versus just treating the symptoms of the cancer? And again, anytime a curve is on the top, that means the treatment is better. And both of these studies showed benefits for secondary chemotherapy. So if 5-FU oxaliplatin stops working, then we should try and give patients a taxane or irinotecan. So then the standard of care in second-line treatment was really changed with the development of a drug called ramucirumab. So, and this was the pivotal trial that looked at this drug ramucirumab. Ramucirumab is what we call a VEGF-targeted therapy. It starves the blood supply to the cancer, and there was some evidence in the early trials of this drug that some patients responded to this, even without chemotherapy. So this was a controlled study. Patients would have to progress on chemotherapy with 5-FU and platinum, and they got assigned to get ramucirumab as their second-line treatment, or really just supportive care, just medical care. And it's not that easy to see this, but again, when the curve is on the top, that means the treatment is better. And there were modest improvements in survival and patients' time on treatment getting ramucirumab compared to supportive care. So this trial actually led the FDA in the United States to approve this drug by itself to treat gastric cancer when first-line chemotherapy did not work. And then here I'm comparing ramucirumab, because remember I showed you those curves earlier that you could get Taxotere or irinotecan, and that's better than doing nothing. But ramucirumab looks very similar to second-line chemotherapy in terms of the survival benefits. They're modest, but ramucirumab seemed to behave as well as secondary chemotherapy. So the next question then was, what happens when we combine ramucirumab with a secondary chemotherapy? And this was another pivotal study, the Rainbow trial, which took ramucirumab plus Taxol. So Taxol is a standard second-line treatment versus Taxol alone. And this improved outcome. Patients did better when they got ramucirumab plus Taxol. They also were on treatment longer, and if you look at the response rate in the middle of that curve, you almost doubled the response to treatment. So almost overnight, once this drug was approved, we now have a better standard of care second line, that patients get 5-FU and oxaliplatin and it stops working. Then we give patients Taxol plus ramucirumab. And this, to me, this trial is another argument not to give the patients the taxane up front. Because you give that taxane up front with DCF or FLOT and you use it up, and then patients progress on that, and ramucirumab is only approved to combine with Taxol. So to me, this is an argument not to use the taxane up front, but to give most patients 5-FU platinum, and then this is not a bad backup option once patients have progression of the cancer on first-line treatment. So we're now awaiting the results of ramucirumab as first-line treatment. This is a completed study that we should be getting results from in the next few months. Patients that get 5-FU platinum, we now know that ramucirumab works as a secondary treatment. Will it work when we give it as initial treatment? So we're all anxiously awaiting the results of this trial, which I think are going to result sometime next year. So I know I'm just going to mention these issues because we're going to have lectures on this later this afternoon. I have shown you that chemotherapy has a modest benefit. You know, about 50% of patients respond. It does improve survivals, and again, I showed you survival averages, so always you have to, when you see an average, say, boy, 50% of patients do better than that. So don't be disheartened by the statistics that you see because they're averages, and again, everybody writes their own book, but conventional cytotoxic chemotherapy has modest benefit. It's not perfect. So targeted therapies, we're really trying to more specifically inhibit growth pathways in cancers by using drugs like monoclonal antibodies, pills that are tyrosine kinase inhibitors, and then also trying to inhibit pathways that are downstream from these driving pathways. So I'm sure we're going to talk about this later, and Manish alluded to it a little bit. The Cancer Genome Atlas Project in the United States, I think, has helped provide guidance and a roadmap for future drug development. They looked at 300 fresh frozen gastric cancer tumors, and they looked at various platforms to characterize the mutations and other abnormalities. And one of their early publications showed that in 150 tumors that were studied, about 26 different significant genes had mutations or genomic loss. And these were the common ones. I circled the two there because cyclin-dependent kinase and PI3 kinase are potentially targetable with drugs. So some of the other ones like SMAD4 and ARID-A and P53, those are what we call tumor suppressor genes. You can't really target tumor suppressor genes, but there is evidence that there's a broad spectrum of genes that are mutated and affected, and maybe in the future we will look at some new drugs to study this. I will say that an early study of a PI3 kinase inhibitor in a trial that was done by Genentech did not bear fruit. So just because you have the mutation doesn't mean the drug is going to work, but it is providing us information that may guide trials. The other thing that came out of this study was amplified genes. Some kind of gene amplification was present in almost 40% of the cancers. And I listed the 5 most common amplified pathways. Probably the most successful has been HER2, but also EGFR. That's targeted by drugs like cetuximab and panitumumab, the MET pathway, and FGF. The problem, unfortunately, again, just because you have the amplification of the mutation doesn't mean the drugs are going to work. And EGFR-targeted drugs have not been successful. HER2 drugs have had mixed success. Some have worked and some haven't. MET-targeted drugs have not been successful. And I know Manish talked about this earlier, but this genomic studies identified 4 subgroups of gastric cancer. Half of tumors are what we call genomically unstable tumors, that they have mutations and gene amplification. A second group has what we call microsatellite instability with lots of mutations. Then there's a subgroup that's kind of bland, that has almost no mutations. And then a fourth group may be associated with Epstein-Barr virus infection. And Manish showed this also. This shows just the distribution of the 4 molecular subtypes. And we're hoping that it's clear that gastric cancer is not one disease, that there are molecular subtypes, and perhaps we can use the genomic profiling to design smarter studies to identify and target these different subtypes with specific drug interventions. Immunotherapy is going to be talked about later. I just want to mention that the two main pathways are CTLA-4 and PD-1, and we'll have a lecture about that later. And then I think this is one of my last slides. What this looks at is these are all cancers. So this bar looks at all cancers. And if you're on the left side of the graph, you have a cancer type that has very few mutations. If you're on the right side of the graph, that means your cancer has lots and lots and lots of mutations. So cancers that respond better to immunotherapy drugs have lots and lots of mutations. And guess what heads the list? Melanoma, right? Melanoma, we've got a number of immunotherapy drugs that are now approved to treat that cancer. So stomach cancer is up there. It's in the top third tier of mutations. So there is a hope that immunotherapy drugs or combinations will eventually prove useful in this disease. So I think then, just to summarize, for locally advanced, sort of inoperable disease, maybe it'll be operable if there's a response. These are probably the cancers that we would consider more aggressive chemotherapy up front, or combined chemotherapy and radiation, and consider surgery if there's a response. In metastatic gastric cancer, I think I showed you evidence that we probably shouldn't operate on everybody that walks in the door. We should probably give chemotherapy a chance first. And I think for the vast majority of patients, 2-drug chemotherapies are preferred. And typically the standard of care now, most oncologists in the U.S. will give 5-FU and oxaliplatin or FOLFOX. But there are other 2-drug combinations, capecitabine cisplatin, capecitabine oxaliplatin, or FOLFIRI. And that secondary chemotherapy, we would probably give Taxol plus ramucirumab. The 2-drug therapy with a taxane, I think you got to be under the age of 60 in most cases. And certainly epirubicin, which I get up and scream and yell at meetings, don't get epirubicin. Just doesn't, most patients don't benefit from it. It adds a lot of side effects. The hope of the future is to identify more sophisticated targeted therapies, and immunotherapy trials are ongoing. And I think the real next step is going to be to look at immunotherapy combinations and identifying which patients are really going to benefit from these therapies. Thanks very much.